अगला वाला. It can present as asymptomatic in digestive tract of humans. At present, there is no animal reservoir exists in the world. Usual infection or infestation usually occurs by drinking water contaminated with feces that contain the cyst of the amoeba, and that is typically called as fecal-oral route. The trophozoite migrate to the large intestine where they multiply. This is a typical diagram showing the course of amoebiasis due to Entamoeba histolytica commonly seen in human beings. The amoeba passes through the stomach as a cyst. As the cyst is acid resistant, it can easily combat with the acid secreted in the stomach. It goes into duodenum, small intestine, and ultimately gets lodged into large intestine. Thereby, it can have access of portal system. Three types of amoebiasis can result from infection. A luminal amoebiasis is least severe form, and that is most of the times remains asymptomatic. Invasive invasive amoebic dysentery is a more common form of infection and characterized by watery stools containing mucus with pain in abdomen and rarely blood. Another form is invasive extraintestinal amoebiasis that is caused by trophozoite carried via the bloodstream throughout the human body and passing through the filters of the circulation. For the prevention of infestation or infection, maintaining clean water is an important way. Amoebic abscess is a complication of this dysentery which is caused by Entamoeba histolytica. The protozoa passes from chronic lesions via the portal vein into the liver and usually into the upper and posterior portion of the right lobe of the liver. Histolytica. Microscopic diagram of Entamoeba histolytica trophozoite showing endoplasm, red blood cells, ectoplasm or capsule and nucleus with karyosome. Liver infection begins with intrahepatic portal thrombosis and infarction. The cytolytic activity starts and leads to liquefaction of surrounding stoma and parenchyma of the liver, resulting in formation of a large abscess. In a 30% of the patient with amoebiasis, you can get a multiple abscesses and continued process lead to cohesions of multiple abscess into a single abscess leading to large liver abscess. Grossly, liver is usually enlarged on all the directions. Liver span is increased. The liquefied material within the abscess is characteristically viscid and semi-transparent. Contained is nothing but a mixture of RBCs, leukocytes, dead broken down liver cells, and this content looks reddish brown colored and typically described as chocolate sauce or anchovy sauce abscess. In early cases, wall of abscess is thin with little fibrosis, whereas as the disease becomes chronic or goes on and on, the older cases have a fibrous capsule because of the chronicity. This is the color of amoebic liver abscess which has been tapped or drained by surgical methods. Clinical features of this parasitic infection: usually a typical history of amoebic dysentery is elicited, fever, chills and rigors because of involvement of liver, loss of appetite, loss of weight, non-productive cough because of irritation of subhyperbatic area, left shoulder tip pain, again because of referred pain because of irritation of diaphragmatic peritoneum and diaphragm itself, pain in the right hypochondrium, and on palpation or thorough clinical examination, soft, tender, smooth, enlarged liver with increased liver span in all the direction. Sometimes you may get mild jaundice. To evaluate this, we need some investigations, and first and foremost investigations which are carried out is the total count, which is always increased. Hemoglobin concentration is on the lower side because of broken RBCs. Liver function test may show altered bilirubin and albumin levels. Prothrombin time may be widened. Serum alkaline phosphatase, SGOT, SGPT levels are altered. Coming to the specialized investigations like USG abdomen, which shows altered echogenicity, especially anechogenic or hypoechogenic lesions in the liver or parenchyma of the liver, and it can be delineated as far as size, location, number of abscess cavities, nature of the liver and its increased span, and this investigation is 90% sensitive. A specialized another is a CT scan with contrast study. Chest X-ray can give rise to indirect evidence by showing raised and fixed diaphragm on right side, which typically called as stenting of the diaphragm, with soft tissue shadows within the area of liver. The treatment: metronidazole is the drug of choice, 100 milligrams given 8 hourly orally. If patient is not going to tolerate oral metronidazole, injection metronidazole 500 milligrams intravenously can be given for 10 to 14 days. And the basic dose of metronidazole is 40 milligrams per kg body weight per day. Alternative drugs like tinidazole 600 milligram 12 hourly for 5 days. IV or oral antibiotics are essential to control secondary infections because of low HB and reduction in the albumin levels as far as abscess is concerned. And most commonly used are broad spectrum antibiotics. Coming to some surgical modalities or interventional modalities of the treatment of liver abscess. Abscess cavity is more than 10 centimeter. Secondarily infected abscess, failure of the drug therapy, and large left lobe abscess, abscess in pregnancy, where the drugs cannot be used, are typical indications for aspiration. This ultrasound guided wide bore needle aspiration should be carried out with all aseptic precautions. And the terminal part or the last part of the aspirated fluid should be sent for various biochemical and microbiological investigations in the form of for the detection of trophozoite study, culture and sensitivity, and so on. Percutaneous drainage is another. Again, it is done under US guidance. A modern pigtail catheter is placed into the abscess cavity percutaneously to drain the pus continuously till total abscess cavity collapses or patient becomes symptomless. As it is a semi-blind procedure, it may fail if there is a thick pus or multiloculated abscesses within the liver. And multilocular abscesses, one of the abscess cavity is drained by the pigtail and rest of the abscess cavity are not in connection with that cavity, hence abscess goes on continuing. Coming to surgery, indications for surgery are even after repeated aspiration percutaneous drainage, abscess continues, repeatedly refilling of abscess cavity is occurring, thick pus which cannot be drained by small beveled needles, pigtails and other things. Multiloculated abscess itself is an indication. Left lobe abscess because of the danger of rupture into the pericardial cavity. Rupture, ruptured abscess on itself is an indication for surgery, and multiple abscesses also an indication for surgery. That means open surgery. After all the precautions and under suitable anesthesia, through transperitoneal abscess approach, abscess area is opened, pus is evacuated. A big Malicot catheter is placed and brought out through a separate stab incision, and the catheter is kept in situ until the drainage stops completely. The complete drainage of pus will be confirmed by repeat ultrasonographic examination. During discharge, the advice is given to avoid alcohol, chloroquine, hydroxychloroquine, and so on. Few complications related to the all surgical procedures is anesthetic problems, bleeding, uh, liver failure, especially seen in cirrhotic patients, spillage of abscess into the intraperitoneal cavity leading to generalized peritonitis and so on, leakage of the bile into the peritoneal cavity or biliary peritonitis or biliary fistula outside because of opening of a intrahepatic bile duct, which is measured in size. Newly, new approach to this access is a laparoscopic approach, which is tried successfully and still under evaluation, and indications for laparoscopic approaches are different. Few of the diagrams showing the liver, then exact site of abscess is confirmed by aspiration with syringe. Abscess cavity is opened. All abscess intraseptal cavities are broken down with finger or sinus forceps, converting it to single cavity. Malicate catheter is kept into the abscess cavity, and rest of the incisions from peritoneum to the skin is closed with additional corrugated drain in if at all something leaks into the peritoneal cavity that will get out with the help of that drain. Another surgical parasite is the nematodes, and the most common is the roundworms. Typically called intestinal roundworms are Ascarias giant intestinal roundworm. Enterobius is a pinworm. Necator is a hookworm. And Trichinea spiralis or trichinosis is a tissue roundworm. Features of the life cycle roundworm: parasite is almost a vertebrates, have a number of reproduction strategies. Most intestinal nematodes shed their eggs into the lumen of the intestine. Eggs are eliminated through the feces. Eggs are consumed in contaminated food and waters. Some intestinal nematodes release their eggs into the soil. Larvae actively penetrate the skin of the host. Inside the body, they travel to the intestine. Other nematodes insist in muscle tissue and are consumed in raw or uncooked meat. The complex diagram showing the life cycle of Ascaris lumbricoides. Treatment for roundworm infestation: anti-helminthic drug like piperazine citrate is a 60 ml is given immediately. Albendazole, mebendazole at night time. Proper nutrition is important, and personal hygiene and drinking of pure water are few of preventive measures for this roundworm infestation. This roundworm can complicate and lead to intestinal obstruction, which is commonly seen in pediatric age group. And the treatment for that is admission of the patient, nasogastric aspiration with Ral's tube, IV fluids. Observation is sufficient in most of the situations. In 48 hours, obstruction will be relieved and child passes worm or bolus worm per annually. Occasionally, laparotomy and milking of the worm bolus into the cecum without enterostomy is needed. Once worm are in hypotonic saline wash per annum makes the expulsion of worms easy. By all the measures, if the intestinal obstruction is not relieved, it can be treated with surgical treatment or removal of the worms by enterotomy, which is rarely done nowadays. Enterotomy should be securely sutured using silk, otherwise reforporation from sutured site can occur by worm toxins or by worm activity in migration. If there is perforation, and in roundworm infestation, the most common site for perforation is the ileum. It can present as a gangrene with peritonitis. Peritoneal worms should be essentially removed. Ideally, ileum should be exteriorized to prevent the suture and breakthrough after closure due to the worm. Sometimes this worm can migrate into hepatobiliary system and so on. So, as per the diagnosis, patient may require ERCP for extraction and stenting of CBD and pancreatic duct. The worms entering into these small ducts, they immediately get died, and if not treated properly, can be converted into calcium sand. Ancylostoma is hookworm, and the most common is Ancylostoma duodenale, which stucks into the duodenum. It hooks itself into the mucosa of the duodenum, hence it is called as hookworm. This is a typical life cycle of a hookworm or Ancylostoma duodenale, from human to the various filters like lung, liver, intestine, and environment. ये हाइड्रेटेड वाला है ना. Echinococcus granulosus is another parasitic infestation, and man or a human being is an accidental host as far as the life cycle of Echinococcus granulosus is concerned. Adult tapeworms release eggs which are excreted by a definitive host. The intermediate host or accidental host ingests this and gets infestation of this Echinococcus. The intermediate host, which is naturally a sieve, is the egg. This egg when goes into the intestine of a ship, it gets converted into larva. And this Echinococcus granulosus typically gives rise to hydatid cyst disease in the human being. And the most common organs involved in the human being are: first filter is the liver, and second filter is the lung. In spite of this, no other organ is immune to the disease. All over the world, even hydatid cysts, intermuscular hydatid cysts, hydatid cysts within the brain, hydatid cysts in the orbital cavity has been reported. Typically, this Echinococcus granulosus gives a cyst within the organ where the egg or larva is sitting, and it is divided into three layers. It has got three layers. A pseudocyst is a advantasia, is an inseparable fibrous tissue due to reactive defensive action of the human body within the organ where the cyst is present. Ectocyst is also called as a laminated membrane formed of parasite itself, which is whitish, elastic, containing or secreting hydatid fluid, which can be peeled off readily from the pseudocyst. And the germinal epithelium is the only living part of the cyst, which is nothing but a lining of the cyst, and that is called as endocyst. This layer secretes hydatid fluid. Broad capsules with scoliosis are nothing but heads of the future Echinococcus granulosus worms. Diagram showing germinal layer, laminated layer, broad capsule, colex, and daughter cyst within the primary cyst. This is surgical picture of a hydatid cyst which is removed from the liver. Multiple cysts looking like pearls. Clinical, it remains asymptomatic. Palpable liver with classical thrill elicited by three-finger test. Jaundice and pain may be present. Feature of anaphylaxis if rupture is seen. Discomfort in right upper part of the abdomen. Dyspepsia, cachexia in children. Weight loss, fatigue, vomiting. Occasionally, splenomegaly, pleural effusion, reactionary pleural effusion, cholangitis, allergic asthma, fever is seen. Investigations: ultrasound is the diagnostic. X-ray often shows in the chronic cases calcifications. CT scan of the abdomen is more accurate in identifying cyst characteristics. Cartwheel-like multivesicular rosette-like appearance. And serologically, ELISA, indirect heme agglutination test, latest agglutination test, immunofluorescence antibody test, immunoelectrophoresis, and the sensitivity of this test is 80 to 95% as far as liver HYDATID is concerned. Cassoni's test, which was previously done with the fluid of hydatid cyst injected subcutaneously, now is abundant investigation. Few of the secondary investigations, laboratory tests for detection of parasites, immunoelectrophoresis specific and virtually diagnostic of hydatid disease, immunoblotting, polymerase chain reaction PCR, more specific, very useful in extrahepatic hydatid disease and calcified non-fertile liver hydatid. Cassonase, as already mentioned, and the sensitivity of that Cassonase test is 75%. MRI, ARCP, depending upon the location of the cells, can be helpful investigations. Treatment, albendazole 4-week cycle with 2 weeks drug-free interval, 400 milligram twice daily. An ideal dose is 10 milligram per kg per day. Praziquantel is 60 milligram per kg along with albendazole for 2 weeks. Mebendazole 600 milligram daily for 4 weeks. Pair is nothing but puncture, aspiration, injection, and re-aspiration. In the selected cases, it is done under ultrasound guided or CT guidance. Under local anesthesia, cyst is punctured using a cholangiography 22 gauge needle through thickest part of the cyst wall. Cyst is entered through non-dependent wall and 50% of fluid is aspirated. Later, a sclerosant like alcohol is injected into the cavity. All multiple daughter cysts are aspirated. A radiopaque dye is injected to see if any communication present. Colicidal agents like 50 to 20% hypotonic saline is injected into the cystic cavity. After 20 minutes, re-aspiration is done. A sclerosant like alcohol is injected. If cyst is 6 centimeter bar, a drainage catheter is placed for complete drainage of remaining, and the catheter is removed when the drain output is less than 50 or nil. The FAIR has gained wide acceptance as it is safe, less invasive, easier to do with very low morbidity and mortality. And the complication and rate of complication and the results of this pair are same as an open surgery. Surgery is still the choice and gold standard therapy for hydatid disease. The abdomen is opened and the peritoneal cavity is packed with mops, especially black colored mops. Fluid from the cyst is aspirated. Colicidal agent, cetrimide, chlorhexidine, alcohol, hypotonic saline, povidone iodine, hydrogen peroxide, any of which is easily available is poured into the cavity after total excision of cavity. Hypotonic saline should be left within the cavity for 15 to 20 minutes to have an effective scolicidal effect. And this is done for avoidance of recurrence of the cyst within the affected organ. Invention in a minimal access surgery has given another way or another modality is a laparoscopic pericystectomy, becoming slowly popular, and the contraindications for this laparoscopic pericystectomy are a deeply situated cyst, densely adherent cyst, inaccessible cyst via small holes, and multiple cysts more than 3, calcified cyst, cyst in other organs, and the problem of a laparoscopy is a pericystectomy is spillage and difficulty in preventing spillage. This is a picture showing a laparoscopic pericystectomy. This is all about surgical parasites. Thank you very much.